Good morning, good afternoon, and good evening, my friends. I welcome you all to our next EBMT 2021 updates. This time we are going to review complication after transplantation. I'm not going to review the GVHD abstract, GVHD management abstract. It's a separate topic and we'll discuss later, although we are going to discuss a couple of quality of life abstract in patients with GVHD. Lots of good abstract. We'll try to provide you pertinent brief information on selected clinical abstract. Abstract not selected for discussion today are equally high quality, but we can't discuss everything in 45 minutes, as you know. Let's see. Yep. I have no conflict of interest to discuss. Let's start with this very important abstract. This was my favorite abstract presented by my favorite physician, Annalisa. Letermovir prophylaxis for cytomegalovirus reactivation in allotransplantation, a multi-center Italian real-world experience. I'm not going to go into the details why CMV infection, CMV disease is bad in our transplant population. We all know it well. And remember our cord blood transplant era and CMV infection issues. We don't want to go about there. My goal is to review letermovir today. Letermovir is an antiviral agent with a novel mechanism of action characterized by inhibition of CMV DNA terminase kinase complex. In a pivotal phase 3 clinical trial, prophylaxis with letermovir significantly reduced the incidence of CMV infection after allotransplantation, which I'm going to review soon. Let's review this abstract first. Authors retrospectively analyzed the efficacy of letermovir in multi-center Italian real-world cohort of 204 patients with CMV seropositivity, standard monitoring and treatment guidelines. Patients were evaluated up to day 100 for the primary efficacy endpoint, and then follow-up continued through week 24 post-transplantation. Author wanted to check if letermovir made any difference in terms of effectiveness in preventing CMV infection, meaning viremia, or CMV disease in patients with high risk for CMV versus non-high risk group. High risk groups were defined according to standard criteria summarized here. For example, mismatch related or unrelated donor transplant, which includes haplo, cord blood, ex vivo T cell depletion, a patient with GVHD, all standard high-risk criteria for CMV disease. Primary endpoints was incidence of CSCI leading to preemptive treatment at day 100, before day 100, post-transplantation, and time to CSCI. Now, CSCI defined as a CMV disease or CMV viremia, reactivation after allotransplantation. I don't know how author came up with this abbreviation. The secondary endpoint was incidence of CSCI at day 168, meaning 24 weeks after transplantation. 66% patients at high risk for CMV disease. We already reviewed the definition of high risk for CMV disease. Infection earlier. A cumulative incidence of CMV infection summarized here. Let's review day 100, meaning week 14 data first. 5% of patients develop clinically significant CMV infection through week 40 after transplantation. And only 2% required initiation of preemptive therapy, and additional 2.5% required treatment for CMV disease. Now let's review data through week 24, 168 days post-transplant. 18% patient develops clinically significant CMV infection through week 24 after transplantation, and 8.3% required initial preemptive therapy, and additional 3.4% required treatment for CMV disease. Very small number. This is way less than we used to have a CMV problem in the past. But look at the number of patients developing CMV infection or disease between week 14 and week 24, almost double, indicating, again, this is my interpretation, we might need to extend the letermovir prophylaxis little longer in high-risk population, especially patients receiving RIC regimen, because action generally start 3 to 4 weeks after transplantation in patients receiving RIC regimen. Now, this needs to be balanced to prevent resistance to letermovir, which most physicians are really scared about. Slide summarizes the cumulative incidence of clinically significant CMV infection at day 100 was 5.4. But this is very important. Cumulative incidence of patients developing clinically significant CMV infection between day 101 and 168 post-transplantation, meaning after discontinuation of letermovir, was 13%. Death was the primary cause of discontinuation within 100 days in 6% of patients. Causes of death summarized here for your review. One related to no death related to CMV. When comparing characteristic of patients who discontinued letermovir to those who did not, MAC regimen was significantly more frequent in patients who discontinued letermovir. Author did not observe statistically significant difference in CMV infection between patients at high risk for CMV and low risk for category for CMV who had a letermovir. Not much issues with adverse events, similar to reported in original study, mostly mild. So author concluded that real-world analysis reports similar efficacy finding compared to the registration trial, which was published in New England Journal of Medicine, which I'll review soon. And other important message was author did not find an increased frequency of CSCI, CMV reactivation, or CMV disease in patients considered at high risk versus those at low risk, suggesting that prophylaxis abrogate the impact of this variable in patients receiving transplantation. Now, before we review next extract, let me review a little more on letermovir. I completed my fellowship in July 6, 2007. My first day as a faculty assistant professor was on 7/7/7, to July 7, 2007, almost 14 years. And as a faculty, if I have to mention two most important clinical innovation in BMT field during my time, again, this is my opinion. Number one, I'll give to post-transplant cyclophosphamide-based allotransplantation. And number two goes to letermovir, according to me. Remember our old days, ganciclovir, foscarnet, side effect. If patients were CMV positive and receiving unrelated donor transplant with thymo, almost 80% chance of CMV reactivation. I think we have used barrels of foscarnet and ganciclovir in the past before this publication. So this was a phase 3 double-blind randomized CMV positive patient, transplant patient. They randomized 2-to-1 ratio to receive letermovir or placebo through week 14 after transplantation, meaning around day 100 post-transplantation. 495 patients with undetectable CMV DNA at randomization. Fewer patients in the letermovir group than in the placebo group had a clinically significant CMV infection. Main message, and this was the main outcome of this study. All-cause mortality at week 24 after transplantation was lower. And all-cause mortality at 48 weeks after, around 1 year after transplantation, was non-significant between the group. Similar to the abstract we just reviewed, prevention of clinically significant CMV infection by letermovir was consistent in patients at high risk for CMV disease and in the low risk group category. So how has our practice changed in this publication? And this is a message to you if you are still not using letermovir. I have no conflict of interest and no one pays me for this presentation. Goal is to help our patient. So how has our practice changed this publication? In our program, we changed our practice from February 2018. We use letermovir primary prophylaxis from day +5 to day plus 100 in patient with summarized here, MURD, haplotransplant, cord blood, and a patient receiving steroid 20 milligram or higher before day 100. And we have some added secondary prophylaxis indication, which is summarized here in case patient starts ruxolitinib, Jakafi, high risk for CMV, we do start on letermovir to prevent CMV reactivation. Bottom line, I reviewed here, I'm not going to read, but I don't remember any patient received foscarnet in past more than 2 years now. Few patients did require ganciclovir or valganciclovir, but I can count the numbers. Remember, patient's name also. And remember, we are also, it's very few number, and we are high volume transplant program. So let's review the second infectious complication abstract. Management of C. diff infection in patient after allotransplantation. Results of infectious disease working party EBMT survey. Again, remember, this is a survey study with lots of limitation. It is very well known that diagnosis and therapeutic approach to C. diff in allotransplant recipient may vary from center to center. Author mentioned that since guidelines dedicated to this specific group of patients are lacking, infectious disease working party undertook a survey to assess the management of C. diff at the EBMT participating center. But I just wanted to let you know that ASTCT, Infectious Disease Special Interest Group, IDSIG, and Committee on Practice Guideline is working on several infectious recommendation, infectious guideline topic. One of the first 10 topic includes C. diff, likely to be published in TCT soon. 2 ID infectious disease guideline articles are already published in February issue of TCT. It includes editorial, preface to series of RD articles. I think Enterobacter article is published and Aspergillosis article is already published. And authors include global infectious disease expert, both from ASTCT and EBMT. Back to this abstract. So author mailed the questionnaire to EBMT center with a response rate from center was 25%. Not bad, we are always lazy to respond to questionnaire many a time. Slide summarizes survey result with incidence of C. diff in EBMT participating center. I'm not going to read the slide because you can see that the results are all over the place in most programs. Again, diagnostic approach to C. diff is also all over the place in this survey. Diagnosis of C. diff is based on stool toxins in most center, while PCR-based tests were performing less than 50% of test center, and very few use the both testing actually. Management guidelines, also all over the place, indicating our society needs to do something to help smaller program and to decrease morbidity and mortality associated with C. diff, and also reduce the cost associated with C. diff management in transplant patient. It's a recurrent hospitalization and lots of work. It adds to everything. Now, information in fecal microbiota transplantation in this survey was very interesting. Very few centers declared they use it, but still a lot higher than in US center. In 35% of the center, increased prevalence of GI-GVHD was observed in patients with C. diff, but objective data on linking are lacking. This is survey, so this is a limitation. So to answer this question, we have one ongoing CIBMTR study. Study number is IN 1802. Title is Incidence and Impact of C. diff infection within 100 days on transplant outcome after allotransplant. Allot analysis is already performed recently. Very interesting data and some practice impactful information. I would say practice changing information. Abstract will be presented at the IACH meeting this year. Now you can see here author's conclusion. When you read this conclusion, feel like authors are expressing frustration in every aspect in approach to the patient with C. difficile transplant recipient. I think our wait will be over soon. We are going to have a consensus recommendation, global recommendation, written by global transplant ID expert, should be coming out soon in TCT. Next abstract, as we all know, lots of HCT, CI, comorbidity index publication in our field, commonly referred as Sorer's comorbidity index. I work with him. I work with Dr. Sorer as a co-chair of CIBMTR regimen-related toxicity and supportive care committee. Lot to learn from him, but it is always interesting to me and always curious which comorbidity is more important in our population, especially in current era. That's why I like this abstract. Nice registry analysis, association of pre-existing comorbidity with outcome of allotransplantation, retrospective analysis from CIBMTR. I don't need to go into details on impact of comorbidity on transplant outcome. We all know details. Presenting author did mention that comprehensive analysis of impact of comorbidity on allotransplant outcome in a large current database is not published. Again, I'm referring it to current database. We have literature, but not lately. The study cohort includes patients receiving transplantation from 2010 to 2018. So nearly 39,000 patients included in this analysis. As expected, pulmonary, infections, and cardiac comorbidity occurred most frequently like prior publication. Interestingly, pre-existing renal comorbidity defined as a creatinine, serum creatinine of more than 2 had the strongest association with non-relapse mortality. And this was the highest hazard ratio, 1.96, among all comorbidities. Hazard ratio of association of other comorbidity with non-relapse mortality was relatively low. It did not exceed more than 1.32. Authors were also interested in HCT-CI in current era. So they did detailed analysis. Interestingly, non-relapse mortality was significantly, but only moderately increased in patients with higher HCT-CI. As hazard ratio of 1.14, if HCTI 1 or 2, increase only to 1.35 in patients with HCT-CI 3 or more. I like the analysis, and their conclusion is well justified by the data. Renal comorbidity remains to be strongly associated with non-relapse mortality. Authors found a weaker association of other comorbidity with non-relapse mortality. Now, when putting the present result in a perspective with previous data from US, CIBMTR, Seattle data, which was basis for HCT-CI, the impact of non-relapse comorbidities on non-relapse mortality has decreased sharply in current era. HCT-CI is not a strong predictor of non-relapse mortality in current EBMT population according to this abstract. Again, this is just an abstract. I don't have the detailed information. Likely explanation for this favorable data summarized here. I'm not going to read, but bottom line, we are getting smarter in selecting patients with more comorbidities. Let's review the few VOD abstract now. Our first VOD presentation is on final primary results from DEFI France registry study, effectiveness and safety of defibrotide for treatment of hepatic VOD after hematopoietic cell transplantation. I don't think we need to review VOD literature today. As we all know, defibrotide is approved both in European Union and USA with slightly different approved indications. DEFI France is a multi-center post-marketing study that collected retrospective and prospective real-world data on patients treated with defibrotide at 53 transplant centers across France. Author presented the final analysis of patients who received defibrotide for severe and very severe VOD after transplantation. Now, severity of VOD definition, EBMT criteria, were published in BMT 2016, reference here. In short, severity criteria is based on time since first clinical symptom of VOD, early, more severe, bilirubin level, more than 5 severe, more than 8 very severe, bilirubin kinetic doubling time, shorter the duration of doubling time, severe, level of transaminases, rapid rise in weight increase, severity, renal function test, all included in definition of severity. So back to this study, of the 775 defibrotide treated patient included in this analysis, 250 received defibrotide for the treatment of severe or very severe VOD post-transplantation, nearly 50% in each group. Median patient age was 45 years, and 1/5, 20% patients were pediatric, meaning less than 18 years of age. A total of 88% patients received allotransplantation. Personally, again, this is my personal opinion, I would have avoided auto patient in this analysis. Maybe auto patients were mainly pediatric, don't know. Among patients with severe or very severe VOD post-transplant, CR rate at day 100 was 53%. The day 100 CR rate was higher in patients with severe, 68%, versus very severe, only 39%. Day 100 cumulative Kaplan-Meier estimated survival was 58% in patients with severe and very severe VOD post-transplantation. Again, survival rate was higher in patients with severe, 74%, versus severe, only 43% patients with severe VOD. Treatment emergent adverse event of interest occurred in 41% patient, and infection and bleeding being the most commonly reported, like reported in the literature. Again, bottom line message is, this is my personal summary of this abstract, is if you have a patient with VOD and patient who is already high risk for VOD, don't wait. Start approved treatment if your patient meets the criteria. Consistent message in all publication, longer you wait, decrease outcome. And if you look at the previous publication, including expanded access, post-Hackman analysis of previous prospective trials, delay in initiation of defibrotide was associated with increased mortality. Another defibrotide study, defibrotide prophylaxis for VOD after transplantation. This was a multi-center, multinational prospective observational study, EBMT pass. Let me be very clear again. I don't have any conflict of interest. I have not received any financial funding from JAS for this presentation. I don't think we need to review the VOD literature today. Previous studies have reported a benefit of defibrotide for VOD prophylaxis post-transplant. But let me remind you, drug is not approved for prophylactic use in patients receiving transplantation. I'm sure you are all aware that JAS company announced about a year ago on April 29, 2020, that enrollment in a phase 3 clinical study of defibrotide for prevention of VOD post-transplant in high risk or very high risk patients was discontinued. Enrollment in study was taught based on a recommendation from the Independent Data Monitoring Committee, which concluded it would be highly unlikely to reach the statistical significance for the primary endpoint of VOD-free survival at day 30 post-transplant in final analysis if study were to complete enrollment. In this abstract, author presented European data, post-hoc analysis, evaluated patients who received defibrotide prophylaxis in this EBMT pass study. Prophylaxis was received in 76 patients. About 40% patients were less than 18 years of age. Defibrotide was administered prophylactic at a median of 7 days on or before transplantation and 20 days post-transplantation for prophylaxis and treatment if those who develop VOD even after prophylactic regimen. So despite prophylaxis, 9 patients, meaning 12% patients developed VOD, including severe in 4 out of these 9 patients. Median time from defibrotide start to VOD diagnosis in this patient was 20 days. And median duration of defibrotide treatment after diagnosis was 20 days, ranges from 8 to 55 days. Remember, all patients in this study had multiple VOD risk factors, which you can review here. You can see here signs symptoms in patients who develop VOD after defibrotide prophylaxis. Multiple feature of VOD in this high-risk population who develop VOD after prophylactic defibrotide. Slide shows Kaplan-Meier estimated post-transplant survival in patients who did and who did not develop VOD. Survival rate was more than 80% in both subgroups at day 100. VOD resolved in all affected patients. No deaths were attributed to VOD. Serious adverse event of interest occurred in 28% of patients receiving this prophylaxis, again, mainly as expected, infection and bleeding. Author did mention that this result should be interpreted in light of this phase 3 defibrotide prophylactic study, which was recently stopped enrollment after meeting the protocol-defined fulfilled criteria. Practically, I want to stress this, practically, we can't use prophylactic defibrotide outside the clinical trial. And this is our third and last VOD presentation. Interesting. Highlights the outcome of anicteric VOD after allotransplantation. Outcome of a defibrotide-treated patient with anicteric or icteric VOD after transplantation. Again, this is very important information. Hypobilirubinemia, bilirubin more than 2 is a key criteria for VOD diagnosis. When we think about VOD, you always think about bilirubin first. But as we all know, in an expanded access study of defibrotide, 23, almost 1/4 of patients had icteric bilirubin less than or equal to 2 VOD at diagnosis. Objective of this study was to examine the incidence of VOD without elevated bilirubin and to assess post-transplant outcome in defibrotide patients in this population. Interesting population. So overall, 104 defibrotide patients with VOD post-transplant were included in this analysis, 62 with severe VOD and 42 with non-severe VOD. Now, those patients with severe VOD, only 16% patients had bilirubin less than 2, and those with non-severe VOD, almost half patient, 48% had bilirubin less than 2. So slightly difficult analysis. Demographic and baseline characteristics were similar across the subgroup, except that bilirubin with less than or equal to 2 at diagnosis tend to be younger than those bilirubin more than 2 at diagnosis. In short, we're comparing 30 patients with bilirubin less than or equal to 2 versus 74 patients bilirubin of more than 4, which are older and more severe VOD in that group. Slide summarizes the transplant characteristic. Again, small number comparison, but not much different. VOD resolution rate were lower in patients with bilirubin more than 2 than those with bilirubin less than or equal to 2 at diagnosis. You can see here, if patient had non-severe VOD, almost all had resolution in patient with anicteric VOD. Again, proves that elevated bilirubin in patient with VOD is a bad prognostic factor. Data showed, in short, I would say that patient with VOD without elevated bilirubin is favorable compared to VOD with high bilirubin. Data showed that day 100 post-transplant survival rates were lower in patients with bilirubin more than 2, regardless of severity of VOD disease. Severe adverse events were not different than prior publication. Individual severe adverse event of interest tend to be more frequent in patients with severe VOD and high bilirubin at diagnosis than other subgroup. Other data. So data suggests that existence of anicteric VOD, even in adults, and highlight the importance of considering VOD without elevated bilirubin in order to facilitate prompt diagnosis and treatment to save more patients. Again, it all depends on criteria. United States, every institution has a different criteria to use defibrotide. In our program, we use defibrotide if patient has hepatic VOD after hematopoietic cell transplantation, at least bilirubin more than 2, with renal and or pulmonary dysfunction. And generally, renal dysfunction is creatinine of more than 2 or double compared to baseline compared with pre-chemotherapy. So let's review a couple of quality of life abstracts, starting with patient-reported outcome in acute GVHD, quality of life finding from real-world study. I like this real world attached to the title. Looks very attractive. Real-world experience, real-world data, attractive title, and it incites us to read the abstract. And if we find the abstract is good, we read the complete article. This is how things work. I don't think I need to review how bad acute GVHD is, especially severe acute GVHD. Authors conducted a real-world study to investigate the overall quality of life in patients with acute GVHD. This cross-sectional survey collected data, collected data using physician-completed patient record forms. Response were analyzed by grade and steroid response, and both of which were reported by the physician. So it's well controlled. Slide summarizes the details of EQ 5D 5L instrument. It's composed of descriptive systemic questionnaire and visual analog scale. Not going to go detail. I don't understand much myself also, but this will be online on IACH website as a recorded webinar. If you are interested in detail, please review there. As expected, greater symptom burden was observed with increasing acute GVHD severity. You can see here all dark green dots on the top. Patient with steroid refractory or steroid-dependent acute GVHD reported more severe and prominent symptoms. Psychological problem increased with disease severity and in patient with inadequate response to steroid. This patient needs good psychosocial support. You have to have a psychiatric, psychologist team seeing your patient with severe acute GVHD. And you also need to have a symptom management team. In our program, we call it pain and symptom management team to help this patient. Also, activity impairment was higher in patients with inadequate response to steroid, daily lifelong activity. Patients with grade 3 to 4 GVHD reported a substantial impairment in ability to do regular activities. Aggressive PT from beginning is a key to help our patient. And we do have an inpatient and outpatient physical rehab center. They visit 2 times a week, 3 times a day, depending on patient's need. If they're outpatient, and daily visiting our inpatient rec room for supervised physical therapy. In conclusion, not going to read, but the important message is this study demonstrates that substantial quality of life and symptom burden of acute GVHD and need for better symptom control with improved first and second line treatment and supportive management. Almost similar study, but in patients with chronic GVHD. Impact of chronic GVHD severity and steroid response on quality of life in patients following allotransplantation, finding from real-world study, again, real-world study. Again, we don't need to review chronic GVHD literature. Quality of life should be systemically evaluated when considering chronic GVHD. This cross-sectional survey collected data using physician-completed patient record forms, like mentioned before. Responses were analyzed by grade and steroid response, both of which were reported by the physician. Hospitalization, healthcare provider visit, and testing were reported by the physician. Again, slide summarizes details of EQ5D5L instrument. It is composed of descriptive systemic questionnaire and visual analog scale. Slide summarizes the patient characteristic. Total 143 patients included in this study. As expected, you can see here some alarming quality of life data, especially in patients with severe chronic GVHD. You can see the green, dark green. Patient quality of life decrease with increasing GVHD severity. You can see the last bar with dark green. Quality of life was lower in steroid-dependent and steroid-refractory chronic GVHD. Patients with chronic GVHD reported more severe and prominent symptoms. You can see here dark green dots on the top in most signs and symptoms of chronic GVHD. Psychological problem increase with chronic GVHD severity. Probably we all know that, but this message with all this presentation and studies, we need to do this. How many of your program take care of all those problems? We need to think that part. Patient with severe chronic GVHD reported a high level of feeling trapped. Greater psychosocial burden was observed with severe chronic GVHD. Again, data highlight the clinical significant impact of chronic GVHD on quality of life. Patients need our help, not only to manage GVHD, chronic GVHD, but also for GVHD-related sequelae. And Tamara presented this very important abstract. Pregnancy, and this is my last abstract, pregnancy and pregnancy outcome after hematopoietic cell transplantation during childhood. A cross-sectional survey of the EBMT Pediatric Working Party. Those who don't know, this is Tamara, a well-known senior in late effect field. Some background information. Slide reviews the cumulative incidence of late effect in childhood transplant survivor. Of those transplanted during childhood, 69% based on literature, 69% male reported infertility and 83% female childhood survivor reported infertility after transplantation. Important message is also, most wish to have a child. Authors, again, this is a survey, wanted to know numbers of pregnancy after transplant performed during childhood. And they also wanted to know the outcome of pregnancy and follow-up of live birth. Authors surveyed patients receiving transplant as a child from year 1995 to 2016. Nearly 63,000 pediatric patients were transplanted in EBMT center from 1995 to 2016. In all 484 patients, a conception after transplantation was reported in a median 11 year after transplantation. Median age of transplantation was 16 years and median age at conception was 25 years. Regarding the fertilization of those conditions with TBI, there were 25 patients who conceived. Out of these 25 patients who received TBI, 13, meaning 52% patients receiving TBI conceived naturally. And 2 of these 13 received low dose, remaining standard dose. And 10 out of 25 patients who were conceived after receiving TBI-based conditioning, 40% patients required assisted fertilization, and 2 used cryopreserved sperms. In patient conditioning without TBI, 93% had a natural conception. 5% required assisted fertilization. In 92% of patients, pregnancy resulted in a live birth. So slide review the summary of the abstract. To me, study has a multiple limitation. I think we don't have denominator at many places here. Maybe they do have information, they will have it in during full publication. But in the absence of other data, results are very interesting and very important to transplant field. Important message is fertility preservation should be standard of care in all patients receiving transplantation. And I thank you very much, my friend. Special thanks to our friend, colleague, well-wisher, who provided their slide to discuss their data with you all today. Recorded webinar will be available on IACH website and also direct link to YouTube videos. Goal is to share the information to help our patient. Thank you all for your patience, and I'll be happy to answer any question via text message in a chat box or QA or via email. Again, thank you very much for your attention. So let's see, we have a QA. Under what circumstances do you recommend allotransplant for multiple myeloma patient at late relapse? Difficult question. So, this is outside it, but we have not done any allotransplantation in myeloma, even late relapse, early relapse, whatever way, for many, many years. And now in United States, we have an approved Carti cell, ID cell. And again, if you look at the transplant community, I'm talking of versus myeloma expert, those who are doing allotransplantation, if you ask a question at many places, large high volume transplant program, I don't think any patient, very few patients are doing allotransplantation nowadays. Let's look at the chart box here. Okay. The same question on allotransplantation. There is no more questions right now. Let's wait for 5 more minutes. 2 more minutes so we can complete 45 minutes. And again, if you have a question, this is my email. Please feel free to call me or text me. Cell phone number is also written here. Okay, do you feel that Carti therapy is replacing transplant now? I don't think so, because we're still doing lots of allotransplantation where we don't use Carti cell. Numbers of patients in AML, myeloid malignancy, particularly increasing patients' age group. More and more allo, we see a 5 to 10% growth in allotransplantation despite multiple non-transplant medications available all over the globe. Carti will replace transplantation, probably I would say in ALL who are relapse ALL, and then in lymphoma. But lymphoma, we do have lots of options, and now we have lots of long-term data. Kymriah 4 years data, Yescarta 5 years data. Almost half of the patient at 4 or 5 years post-Carti infusion remain in remission. So those are the places we will see Carti is replacing allotransplantation. In our institution particularly, very few allotransplantation for lymphoma nowadays compared to 5, 6 years ago. Lot less. So yeah, these are the things. Myeloma, I don't know, cost is a factor. If you look at the publication, there was a newsletter in New York Times or some newspaper, ID cell, which was only approved Carti cell in myeloma. I think cost is around $400,000 plus administration cost. So we'll see. It's challenging time. We don't know. I don't know whether it will replace Carti or not, but still auto-transplantation is standard of care in myeloma inpatient as a consolidation and also as a salvage therapy. So I have a question that which gender is more prone to develop VOD? It is not a risk aspect. So, if you look at that, there are some data that female patient higher risk, but if you look at the larger big analysis, I don't think gender has any impact on developing VOD. Please read out the question. Yes, I'm going to read. So next question is, letermovir is a good drug, not having to use foscarnet, and cyclophosphamide, but impact on survival is low or none. Why is so good for you? Because it saves lots of your resources. This is what our personal opinion. Patient day stays outpatient, quality of life. Think about giving foscarnet for 4 weeks for CMV disease, monitoring, admission, hospitalization. So this is what, and we have our pharmacist, which is considering cost analysis on prior versus current data. It will not be standard good analysis, but it is still cost effective and best quality of life, let me tell you. Personal opinion in a large volume transplant program. So I have a next question. What would you, with allo transplant in patient with renal impairment? If so, from which threshold? So we do have a patient with mild renal dysfunction. We do use post-transplant size sirolimus-based protocol without calcineurin inhibitor based on some published data. But those patients with CRI, renal failure 3 or 4, we don't do allotransplantation. There are specific patients with mild impairment, but no other major comorbidity and no alternative option. We do consider allotransplantation in our not calcineurin inhibitor regimen. Last part regarding ALL in reflex. Thank you for answering. Perfect. Let me know if you have any more questions. We have 2 more minutes. Again, friends, thank you. Well, thank you so much for attending this session. Session will be available on IACH website, a recorded webinar. All slides will be there in case you want to review the slides in detail or you want to review the references in detail. Again, thank you so much. We will conclude the session now.